Okay, I'm pretty sure more people will log on if they can. If not, then it will be recorded and posted on Canva for you. So I got a lot of emails. Y'all appear to be nervous about the exam. So I just want to kind of ease some of your anxiety. Again, this exam is on cardiac medications, respiratory medications, and then again, looking at the labels and dosage. Okay. Um, so we'll start off with the cardiac medications. Okay, so that's dealing with medications for hypertension, dealing with medications for heart failure. Remember, I'm only talking about one medication for anti-dysrhythmias. What's that one medication that I said we were going to discuss?
Adenosine.
Adenosine. That's the only one. So if you're looking at all the other stuff, don't. Okay, we're only talking about adenosine. So medications for hypertension, medications for heart failure, adenosine, and then medications for chest pain. We're also going to be looking at medications that decrease cholesterol. Okay, and then that it also includes, like for hypertension and heart failure, that also includes diuretics. And then for respiratory medications, it's those medications for the upper respiratory system, like cough suppressants, expectorants, medications for allergies, decongestants, and then medications for the lower respiratory tract, which is basically just the lungs. So we have bronchodilators, we have corticosteroids, we have mucolytics to help decrease that mucus. All right. So I'm going to start off talking about cardiac medications. Again, I'm not going to talk about the different conditions like hypertension versus heart failure. I'm just going to talk about the class of cardiac medications because, again, all these medications are used for several different cardiac disorders. All right. So the first one we talk about, right? And the main thing with ACE inhibitors was what? How does it work? Somebody tell me, how do ACE inhibitors work?
Vasodilators.
It blocks, it converts, so angiotensive 2 doesn't start.
Right. So we know angiotensin 2 vasoconstricts. So if we block that conversion, we're going to have vasodilation. All right. So it's a vasodilator. What else does it do? It decreases something. What does it decrease?
It decreases your heart rate.
No.
No, it doesn't decrease your let's see.
It decreases sodium. Okay.
Yes.
So what happens is it's going to cause you to excrete sodium. So if you're excreting sodium, what else are you going to be excreting?
Urine and water. I mean, fluid.
Fluid, water. Okay. So that's how it works. It's a vasodilator. So it's going to open up those blood vessels, and it's also going to decrease sodium. Whenever it decreases sodium, wherever sodium goes, water follows. Right. So if it's going to excrete sodium, it's going to excrete water. And because I know it does those two things, that I know that this medication is good for hypertension, it's also going to be good for what else?
Dropping your blood pressure.
Okay. What else? What about heart failure? Okay. So ACE inhibitors, they're good for the health.
Patients with heart failure and blood pressure.
So it's good for heart failure and blood pressure because of how it works. It's going to vasodilate. Anytime we have vasodilation, what happens to the blood pressure?
It drops.
It drops. Anytime we get rid of sodium, what are we also getting rid of? Fluids. Okay. So that's how ACE inhibitors work. We know it's good for hypertension. It's also good for heart failure. So another thing that I want to talk about with ACE inhibitors is the side effects. All right. So why do I have that? Okay. All right. So tell me some side effects of ACE inhibitors.
The ACE inhibitors, the common side effects are that dry cough.
All right, that dry cough. What else?
Angioedema.
All right,
high potassium, and it increases your potassium.
Okay. Does it increase potassium a whole lot?
It just says on here one of the side effects is hyperkalemia.
So So
Um,
it will increase it a little bit, not a whole lot though, but yes. All right. So
Okay.
dry cough is something that we always gonna see. All right. That's the
Mhm.
main side effect, the dry cough. But angioedema, although this is not common, it's deadly.
And that's one of the adverse, I think, effects to to the ACE
Correct.
inhibitors.
Correct. So, so angioedema, tell me what that is.
Swelling of
Uh,
the lips, the throat,
Mm-hmm. Swelling of the lips, of the
facial
throat,
facial edema,
facial edema. Yes. So why am I concerned about facial edema?
because it'll
anaphylaxis.
anaphylactic, it can close your airway, the patient can stop breathing.
Okay. Tell me, have you noticed any swelling? Or the patient may say, my lip feels funny, or my tongue feels heavy. That's when we tell them stop this medication. They need to seek medical treatment because that may be the start of angioedema. Okay. So that's a big thing with ACE inhibitors. Okay. Now, sometimes people don't like the side effects of ACE inhibitors. They don't like that dry cough, or they don't like, or maybe they've had angioedema before, and we know that, we don't want to give them that. All right. First of all, before I get into that, what is the prefix to ACE inhibitors? What's the prefix?
The Pril drugs,
All right. So these are our trail drugs, like lisinopril.
lisinopril, enalapril, captopril.
Correct. All right. So if you see Pril on the exam, automatically that's an ACE inhibitor. Okay. But if somebody can't tolerate ACE inhibitors, or they just don't like it, or whatever the case may be, okay. How do I erase that? Where's the eraser on here?
I think they say a lot of people that can't tolerate the ACE inhibitors, they switch them to the ARB.
Okay, correct. The ARB, because they work similarly. Okay. So with the ARB is the angiotensin receptor blocker.
Receptor blocker.
All right. So it's basically going to block angiotensin 2. All right. We know anytime angiotensin 2 is blocked, what's going to be the therapeutic effect?
It's gonna dilate the arteries from like it's blocking them from constricting, so they're gonna dilate and widen.
Correct. We're going to have
Basically,
vasodilation. Anytime I have vasodilation, what's going to happen to my blood pressure?
it will
Drops.
decrease.
It's going to decrease. It's going to drop. Okay. And so ARBs, what is the the suffix for ARBs?
The
Sartans.
sartans. So
Sartan,
like losartan.
like losartan, valsartan.
Mhm.
All right, these are ARBs. Okay, they work very similarly to ACE inhibitors. You may have some of the same side effects, not the dry cough, not a whole lot of angioedema, but you will have like that first dose drop in the blood pressure. They may be dizzy, things like that. Okay. Questions about ARBs?
Mm-mm.
For the ARBs, they say that their patients are prone, or the adverse reaction is liver toxicity. Is that because it has to go through the liver to activate, or
It does have to be metabolized by the liver.
okay?
It does have to do that. Yes. And a lot of times with these medications, you may notice some swelling in their ankles. Not a whole lot, but
Yes.
some swelling. You may notice that, and that's normal. That's a normal side effect. However, if they start getting like generalized edema, facial edema again, then that's a problem. But a lot of patients who are on ARBs, they will have some minor dependent edema, which is that edema that's in their ankles. Okay.
Okay.
So because of how it works, it's a vasodilator. I know that it's good for blood pressure. Would it also be good for heart failure?
Yes.
Yes, because again, vasodilation is going to drop that blood pressure, which means your heart doesn't work as hard. The whole problem with heart failure is your heart doesn't pump well. So if I can make it to where my heart doesn't work hard, then it can pump a little better because it has time to relax and pump more efficiently.
Feel and pump. Yep.
All right, questions? All right, so let's talk about ACE inhibitors. I'm not ACE inhibitors, let's just talk about that. Alpha blockers. All right, we're gonna talk about alpha blockers. Okay, first of all, with alpha blockers, what is the suffix?
Zosyn,
All right, so Zosyn. Okay, these are
Tarazosyn.
our Zosyn drugs. Again, how do alpha blockers work? What's the therapeutic effect that it has?
It's gonna block receptors in the arteries and the smooth muscle.
And again, guess what it's gonna cause? Vasodilation.
Vasodilation, yeah.
Anytime I have vasodilation, what's gonna happen to that blood pressure?
It's gonna
Decrease it.
drop.
It's going to drop. That is correct. Okay. So we don't have to worry about like the dry cough or things like that. All right. But we do have to worry about like the same old low blood pressure type of side effects, like dizziness, all that kind of stuff. Because it's a vasodilator, we want to avoid other things that can vasodilate, like heat, being outside too long, hot tubs, that sort of thing. Right.
Yep.
Another thing with alpha blockers, not only is it good for blood pressure, but it's also good for something else that's not really related to cardiac. What is that?
Men that have enlarged prostate.
So it's good for BPH. All right, so it treats BPH. Okay, so if we have a male that's taking tamsulosin or something like that, okay, and they may question like, why am I taking this? This is a blood pressure medication. Why am I taking it? How are you going to respond to that patient?
Good question.
So if it's a male and they
Because they
say,
have difficulty urinating with that, right?
yeah. So with BPH, yes, they have difficulty urinating. So what this alpha block is going to do is going to make it easier for them to urinate. Okay. So we'll tell that male, no, you don't have high blood pressure. However, you have BPH, which is an enlarged prostate, which makes it difficult for you to go to the bathroom. So this medication is going to help you go to the bathroom better. All right. Are they going to still have the same blood pressure side effects?
Yes.
Yes, because again, it is still what? A vasodilator.
Yeah.
And anytime we have vasodilation, what happens to our blood pressure?
Decreases.
Gonna drop.
It's going to drop.
So do they have to be monitored extra because they don't have high blood pressure, and with them being on one, it can drop their blood pressure too low?
So usually it's that very first dose is going to drop it super low because
Okay.
they've never had high blood pressure. We don't know how low it's going to drop it. But once they had that first dose and we see how low it's going to drop it, then we can adjust their dose. But they still, every so often need to check their blood pressure because again, it's going to drop their blood pressure.
Okay.
Make sense?
Yes,
Mhm.
ma'am.
So that's the basic thing with alpha blockers. Okay. It's indicated for hypertension, but if we see it in the male and they don't have hypertension, then we know they're taking it because they have BPH and they're having trouble urinating. Okay.
And then one of the things that it was saying in our book, the teaching alert, is the men that are taking the the type 5 inhibitors for ED, they can't take that with the alpha blockers.
Right. And so that's something we talked about too, because medications for erectile dysfunction, how do they work? They vasodilate. They're opening up the blood vessels so more blood can go to that area down there so they can have that erection. But again, because it's a vasodilator, what's going to happen to their blood pressure?
It's going to drop too low.
It's going to drop. So we tell patients, if you are already on something that's going to vasodilate, you should not be taking those erectile dysfunction drugs. Remember, we talked about sometimes these men will pass out during the act. And again, because their blood pressure is dropping too low.
Okay.
Make sense?
Yes, ma'am.
All right. So beta blockers, what's that suffix?
OL.
OLOL. All right. We talked about we may have beta 1 blockers. We may have beta 2 blockers. Okay. Beta 1 blockers. If it's only beta 1, what do we also call that?
Cardio selective.
Cardioselective, which means it's selecting just that beta 1 blocker. The beta 1 blockers are called cardioselective. All right. And then most other beta blockers are non-selective. All right. Non-selective beta blockers just means that it contains beta 1 and beta 2 blockers. Okay. So who would benefit from cardioselective beta blockers?
Patients that have a history of asthma, COPD,
Smokers.
type of breathing issues.
That's correct, right? So
Mhm.
if I have a patient and they have a history of asthma and they are taking a beta 1 blocker and they're complaining of difficulty breathing, what should the nurse do?
Give them a beta 1 like metoprolol.
Right, and we're going to contact that physician and say, hey, this patient has a history of asthma and they're on a beta 1 blocker. Now they're having difficulty breathing. And that, so we're going to recommend that they're on like a non-selective, they need to be on a cardioselective beta blocker.
Yeah.
Yeah.
Okay, I'm sorry, I had it mixed up, but they need to be on a cardioselective, okay? Because anybody who has any type of lung issue should not be on a non-selective beta blocker because it contains a beta 2 blocker, which is going to constrict their airways. So again, cardioselective beta blockers, anybody can take them, but we really want, if we have to put a patient on a beta blocker who has lung issues, I want them to be on a cardioselective beta blocker. Does that make sense?
Yes.
Correct.
All
But
right,
if their heart rate is below 60, we can't give them beta blocker
tell me why.
because it's going to make their heart rate decrease even lower.
So is this typical with all medications for high blood pressure or specifically for beta blockers?
Well,
What'd you say?
no, because the beta blockers are more so for the heart rate, but it does treat hypertension.
Correct.
So
Um,
other medications for hypertension may increase the heart rate.
right.
The beta blockers specifically decrease the heart
Sure.
rate, which brings us to our next indication. So it can be used for hypertension. It can also be used for those tachycardias, okay, because it's going to decrease that heart rate. Okay, so we teach that patient to please check their heart rate before they give themselves a beta blocker. Of course, they're going to be checking their blood pressure, but they definitely need to check their heart rate. Does that make sense?
Mm-hmm.
Questions about beta blockers?
Mm-mm.
How do they work again?
It's gonna vasodilate.
Oh,
It's gonna decrease your heart's the work of your heart.
Mhm. So that means
Uh,
it's good for hypertension, it's good for those tachycardias, and it's good for heart failure as well.
mhm.
Make sense?
Yes.
All right. So the next one I want to talk about are those calcium channel blockers.
Calcium.
All right.
channels. Is that the?
It's gonna slow the calcium down from going into the heart cell, like to the heart.
Okay, so how does that benefit? What is it gonna do to the heart?
It's gonna slow it down. It's not gonna require as much oxygenated rich blood.
Correct. So the way calcium channel blockers work, calcium actually helps the heart contract. All right.
Mhm.
So if we're blocking that calcium channel, that calcium can't get into the heart. So instead of the heart contracting so much, it's going to relax. Okay. So if the heart doesn't have to work as hard, that means it's going to lower the blood pressure. And it's also good for heart failure when we have those patients who their heart's not pumping well. So we give them a calcium channel blocker and it kind of relaxes the heart. Okay. It's also good for chest pain as well. So beta blockers is good for chest pain. Calcium channel blockers are also good for chest pain. All right. It's going to relax the heart. Okay. So question, what are some of the side effects?
Constipation.
Constipation. And again, those same low blood pressure type of side effects as well. Dizziness, all that kind of stuff.
Hypertension.
Now, What is the suffix for calcium channel blockers?
Peen drugs.
Yeah. These are your depine drugs, like amlodipine, nifedipine. Okay, so if you see depine on there, I know it's a calcium channel blocker. It's going to relax my heart. Okay, it's going to be good for hypertension. It's going to be good for chest pain. It's going to be good for heart failure. Okay,
And that's the choice for African Americans, right?
yes, this is the if this work is research has found that calcium channel blockers work better, yes, for African Americans. Okay, questions about calcium channel blockers?
There was one question in our study guidebook
Mhm.
about the calcium channel blockers causing the skin disorder or the
Steven Johnson
Yes.
syndrome. Okay, so that may have, it's very rare.
okay.
It's a very rare side effect, but with Stevens Johnson syndrome, that's where you got like your skin starts to get this rash and it kind of turns into sores and it kind of, your skin kind of flakes off. It's a really kind of irritating, it's hard to look at type of disorder, but it does happen, but it's very rare.
Okay.
Okay. And again, these are your depine drugs. Okay, calcium channel blockers, really good for hypertension, chest pain, and also for heart failure. Okay. So does it vasodilate?
No.
No,
No.
it does not vasodilate. Okay. All right, let's talk about some diuretics. We have 3 classes, right?
Yes.
Or really 4. All right. So tell me, let's talk about the first class. Which one we gonna talk about first? Well, first of all, if somebody has hypertension,
Thank you.
if somebody has hypertension, what is the first line treatment if it's going to be a diuretic? Which class?
Thiazides.
That's correct. Thiazide. Yeah, thiazide diuretic. Okay. So they're going to be losing sodium. They're going to lose fluid. And what else are they going to lose on a thiazide diuretic?
Potassium.
Sodium.
They're going to lose sodium, yes. They're going to lose fluid less, yes, and a little bit of potassium. Okay. But a lot of times thiazide diuretics can be combined with other medications for hypertension. Okay. The suffix for thiazide diuretics is thiazide, like hydrochlorothiazide. Okay. So we still worry about anytime you're losing fluids, we worry about a drop in the blood pressure. We worry about risk for dehydration. They may have a dry mouth, that sort of thing. Okay, with older adults. Go ahead.
Yeah, a lot of ours we have they combine them with the beta blockers.
Yeah. So it kind of helps with it kind of has that like synergistic effect. So we're gonna have a lower pressure, but if you have somebody that's on a beta blocker is not going to remove that fluid. But if we
Fluid.
them with that diuretic, then they'll also lose fluid that has like a better low blood pressure response. Okay. Then we have another class of diuretics. Which are they?
Loop diuretic.
Loops.
Loop diuretic. All right. This is medications like furosemide or Lasix. And we already know that loops make you do what?
Lose
Make it
potassium.
lose potassium.
Yeah. So we're going to be losing sodium. We're going to be losing water. We're going to be losing a whole lot of potassium, a lot of it. Because I know that, what am I going to teach my patient?
They
You
have
wanna
to
put one up.
supplement or increase their foods with potassium.
Yeah.
What are those foods that have potassium in it? What foods have high potassium?
Potatoes, bananas, avocado,
Your
kiwi.
leafy greens.
So cantaloupe, apricots, those sorts of things. Okay. So that's what loop diuretics. Okay, and loops are very strong. All right. They work very similarly to thiazide diuretics, but loops are more potent. They work faster. You're gonna lose more fluid. You're gonna lose more potassium. Okay. Then we have another type of diuretic. Which one is that?
That osmotic diuretic,
Okay.
that mannitol.
All right.
The
So
potassium sparing.
All right, so let's talk about osmotic diuretics. Okay, you're gonna be losing a whole lot of fluid at one time. Okay, so when do we use this medication?
Only in critical situations.
Critical situations like,
Patients have fluid on the brain, or when the kidneys need to be tricked.
correct. All right. What's the route for osmotic diuretics?
IV.
IV.
Yep, IV. What has to go on the tubing?
A filter.
A filter.
Why?
So it
Because-
doesn't get crystallized.
It
Correct.
interacts with drugs previously given.
Questions about osmotic diuretics. I'm not going to go into a whole lot, but I just need you to know it's not for just hypertension or heart failure. It's not for that. It's for
No.
those critical situations. Our kidneys aren't working. I need to trick it to work. Our brain has too much fluid surrounding it. Okay, that's what osmotic diuretics are for. Okay, and then our last class of diuretics are those potassium sparing. All right.
Yeah.
What are some examples of potassium sparing diuretics?
Spironolactone.
Right? So those actones, okay? With that, I know that I'm going to be holding on potassium, okay? Holding on to potassium. So do I tell patients to eat a whole lot of potassium while they're on this medication?
No.
No.
Okay, because I worry about them collecting too much potassium. Okay, now this is really good for those patients who already, we don't want them to lose any more potassium. Okay, we don't want them to lose potassium, so we may put them on this potassium sparing diuretic. Okay, but are they still going to lose sodium and water?
No.
Yes.
No, huh?
Yeah, they will still lose.
They're still
and
lose
water.
sodium and water, but just not any, the potassium will stay within normal limits.
Okay.
Correct. Makes sense.
Okay. Okay. Yes.
And all diuretics are going to have the same side effects outside of like the potassium type of stuff. They're going to be losing fluids. So what am I worried about when somebody's losing fluids?
Dehydration.
Dehydration. What else? What about with that blood pressure?
Yeah.
Decreased blood pressure.
That decreased blood pressure. So I tell them to change position slowly. That, all the
Mhm.
same blood pressure type of considerations. Okay.
Dr. Dyson, do I remember you the other day saying that of all the diuretics, the potassium sparing is the safer if during pregnancy?
Yeah.
Okay. Because when I looked
So-
it up on the internet, it didn't say that, but I thought I recalled you saying that.
It's the safer, because when you think about the other ones, when we're losing potassium is very important, especially for the heart. When somebody who is pregnant, their heart is pumping not only for themselves, but is pumping extra because you now have another whole living being there.
Mhm.
Okay. And I don't want to take away from anything that the heart has to do. Does that make
Okay.
sense?
Mhm.
And we know potassium is really important for those heartbeats. And so I don't want them to lose too much because I need that. I needed to be able to pump. I needed to contract really strong because it's beating not just for me, but for somebody else as well.
Correct. Okay.
Okay.
What happens, Dr. Tyson, when a patient gets too much calcium or potassium? Like,
So it's gonna throw them out of rhythm. Okay.
okay,
Because remember, both of those help the heart contract. Okay. So
Right.
too much of it, the heart's gonna start pumping out of rhythm, it's gonna start pumping too strong. And sometimes when it pumps too strong, it doesn't pump in a nice regular rhythm. And so we're gonna throw them out of rhythm. And then we have to worry about, when the heart's out of rhythm, is it pumping effectively? Is the blood moving anywhere? That sort of thing. So too much
Okay.
potassium, too much calcium is gonna throw that heart out of rhythm. And again, sometimes too little calcium, too little potassium can
Mhm.
also throw that heart out of rhythm
Mhm.
okay.
to a different rhythm.
Yeah.
Okay. Let's talk about those potent vasodilators, meaning that's its major job is a vasodilator. Okay, it's not something secondary that happens. It just straight up, it goes in there and it vasodilates. What are some of the vasodilators we talked about?
Hydralazine, the nitrostat, isobord. I can't never say that word. Yeah, that word.
Isosorbide.
Yeah.
Dinitrate, isosorbide, mononitrate. Okay, so it's medications like hydralazine, nitroglycerin, isosorbide dinitrate, isosorbide mononitrate. Usually these medications are used when we really need to get in there and I need to vasodilate quickly. All right, and
Mhm.
most of the time, when do we need to go in there and vasodilate quickly?
When someone is having chest pains.
Chest pain, correct. When someone's having chest pain, the only time you have chest pain is if your heart does not get as much oxygen as it needs. And that's a problem. All right. So that chest pain, our heart's letting us know, hey, I need more oxygen. If I don't have this oxygen, I'm going to have a heart attack. Okay. So when somebody's having chest pain, it's because their heart is not getting enough oxygen. And I need to open up those arteries, so those vessels, so that heart can get the oxygen that it needs. Okay. Because I know it's going to vasodilate, what do I automatically know is going to happen to my blood pressure?
It's gonna
Can
drop.
drop.
It's going to drop. All right. And again, I have all those same blood pressure dropping type of side effects. I know that I don't want them outside in the heat and all that kind of stuff because it's a vasodilator. All right.
Mhm.
One of the major vasodilators that we use is nitroglycerin because it comes in so many forms. It can be fast acting, it can be long acting, it can be by mouth, it can be sublingual, it can be in a paste, it can be in an ointment, it can be in a patch. So many different ways we can give nitroglycerin, right? What's the major side effect of nitroglycerin?
That's
Tachycardia.
pounding headache.
Pounding headache. Yes. So if I'm putting on a paste, what does the nurse need to wear?
Gloves.
Gloves. Correct. So if somebody's taking nitroglycerin sublingual, where do they put it?
Under the tongue.
Under their tongue.
How do they know that it's still working?
It's gonna tingle.
It's gonna have like a little tingling sensation. Okay. Let's say somebody has chest pain. What's the first thing they need to do?
Move slow.
First thing they need to do. Chest pain. What's the first thing they need to do?
Lie down.
Lie down. So whatever they need to do, they need to stop moving. All right.
Stop moving. What I meant to
First
say myself.
thing,
Oh,
yes.
Okay.
First thing somebody needs to do when they're having chest pain is stop moving. Okay.
Okay.
Then they can take one nitroglycerin tablet, put it under the tongue. All right. If in 5 minutes it doesn't work, what is the very next step?
Call 911 and then they can take another one.
Call 911 and take another one. Okay. 5 minutes later, it's still not working. What they need to do?
Maybe
They
at
can
the
take
hospital.
another dose.
Okay, so they can take another one. So they can take up to 3 tablets sublingually 5 minutes apart. Okay.
Mhm.
Should they drive themselves to the hospital?
No.
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 Because if they're
Why?
by the third, if they're by the third nitroglycerin, they're more than likely having a heart attack.
Correct. What's another reason I don't want them to drive themselves though?
They can have a heart attack while they're driving.
Give me another reason. What's this medication going to do?
Gonna
How does it work?
it's vasodilating your arteries.
What's going to happen to that blood pressure?
It's gonna bottom
Drops.
out.
It's going to drop. And we've given them 3 of them. They take 3,
Yeah.
that blood pressure is going to be extremely low. So if they drive themselves, they may not be with it. They may pass out. Does that make
Mhm.
sense?
Yes.
So all of these are vasodilators. It's going to have like the same side effects and all that. But nitroglycerin is the one that you can take sublingual, put it under the tongue, up to 3, 5 minutes apart. If somebody has like a nitroglycerin patch, right, that means they're getting like a little bit of nitroglycerin at a time. It's not for when they're having like active chest pain. It helps to prevent chest pain. But sometimes they can become tolerant to the nitroglycerin patch. So what is one thing I can do to prevent tolerance?
Take the patch off at night and put a new one on in the morning.
Correct. Take it off at night. Why am I taking it off at night?
Because it's the likelihood of them having a heart attack at night.
Correct, because when you're at nighttime, you're not doing a whole lot of moving.
You're
You don't
not
need a whole lot
active.
of oxygen.
Yeah.
Make sense?
Mm-hmm.
All right. All right. All right. The next thing I want to talk about is adenosine. What is adenosine?
For SVT.
All right. So supraventricular tachycardia. All right. How does this medication work?
It resets the heart.
Yeah.
Basically resets the heart. It's like a remote control when your TV not working. What you gonna do? Turn it off, turn it back on, and see if it works. So that means what is gonna happen when this medication is given in this this life-threatening situation? What's gonna happen to my patient?
You know, gonna wait for her heart to come back on.
All right. So they're going to go into a systole, okay, which
Oh,
means
yeah.
a flat line. Okay.
Yeah.
A means without, systole means contraction. So without contraction. All right. So the little uptick and stuff like that, like when like on the EKG machines, when you see that, that's basically movement of the heart, a contraction of the heart. But if you see this, that means there's no contraction. It's a flat line. It's asystole. All right. That's what this medication is going to do. It's going to stop their heart for about a few seconds, and then the heart should start beating again. If it doesn't, you know, that's one of the things that we may have to worry about, that we got to do something totally different. Like, you know, they went into cardiac arrest, which means even if I didn't give this medication, something bad was probably going to happen. But adenosine is used to stop the heart. It resets the heart so it can go back into that normal rhythm. All right. Think about those ER shows y'all watch, Grey's Anatomy, like the climax of the show, when they push this medication and then everybody stops, turns towards the camera, and there's a pause for a couple of seconds. Everybody's breathing all heavily. It's this whole big buildup. And then beep, 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 and then everybody starts breathing again.
Is the patient usually awake when they do this?
A lot of times, no. Mm-mm.
Because I Googled this just to kind of see, because I mean, I've never seen it. I don't work in ER or anything, so I've never seen it. And, you know, one that I watched, the patient was awake. And I mean, like after they did it, I mean, she was nice and calm. And she's had several of these done. So she's known, you know, with cardiac issues. And they asked her, you know, what did she feel, how she felt. And I mean, they had her talking to the camera. She was aware that she was on YouTube, and she just kind of told what she experienced. So I was like, I was just confused.
Yeah, a lot of times they're not. And if they are, like, you know, awake, they're not alert. Like they don't know what's going on, because
I
when
mean,
your
she was
heart's
alert and calm and just, you know, kind of said she felt
odd.
funny, that it was warm, and I'm
That's,
gonna show it to you tomorrow after the test.
yeah, that's kind of odd. Because just think about it, when your heart's not pumping well, like it's like not
Yeah,
only is it not, you know, getting to your organs, it's not getting to your brain.
this threw me off altogether. I was like,
Yeah.
this is not what they said in class, how this was.
Yeah, definitely show me that, because that's odd. But you
Okay.
know, stranger things have happened. That's how you know man didn't make our bodies, because we don't control like the odd things that happen.
Yeah, it would be the one video I pull up that just is totally different.
Yeah. All right. So we talked about medications for you know, we talked about a lot of different classes. Let's talk about the cardiac glycosides. Okay. That main medication that is a cardiac glycoside, that is digoxin. Tell me about digoxin, y'all.
Very narrow therapeutic index.
Yes, it's a fine line between it being therapeutic and toxic. How do I know that a patient's toxic?
Gotta check
The
their dig
potassium
level.
is low.
The potassium is low also. So wait, let's stop there. Potassium low. If a patient is on a loop diuretic, because you know they got heart failure, they got a whole lot of fluid, they're on a loop diuretic, and they're on digoxin, what am I worried about?
Toxicity.
Toxicity, because low potassium levels put them at risk for toxicity. Okay. All right. So tell me some other things that can show us that they're possibly in toxicity.
They
Here
receive
they
lights
lose
or
any
something.
Right. So halos around the lights, they see flashing lights of color, that sort of thing. Okay. So and their pulse rate will drop below 60. Okay, so that means I need to check a certain pulse rate before I give this medication. What pulse should I be checking for a full minute?
Apical.
Their apical pulse, yes, because I know that not only do I need to count their their heart rate, I need to listen to see if I hear any dysrhythmias. Okay, because that's also a sign of toxicity. It's going to throw their heart out of rhythm. Okay. Questions about digoxin. So on the test, if I say a nurse checked the radial pulse and the pulse was 50, what should the nurse do?
And try again.
Check
What
the
she gonna
apical
try?
pulse.
She gotta check the apical pulse. All right. Don't
Right.
get those confused. Just because you say,
Mhm.
oh, I gotta check the pulse. Don't say certain pulse you have to check. You have
An
to
apical
check
pulse.
that apical pulse. Correct. Okay. Questions about digoxin. It does cause some GI upset as well. But the main thing I worry about with digoxin is their potassium level. I am worried about their vision. I need to be checking for toxicity. I need to be checking that heart rate, making sure that I'm checking the apical pulse because I need to be listening to the rhythm as well.
Mhm.
Make sense?
Yes.
Yes.
All right. Let's talk about medications that prevent clotting. So these are anticoagulants. We talked about 2 of them, right?
3, huh?
Well, you got
Well, I
heparin
guess
is
all
what they
2 are
give
the
in the
same.
hospital, and
heparin
then
and Coumadin and
they got the
warfarin. Okay, yeah, they're the same.
All right. So we got heparin. Let's talk about heparin first. All right.
Yeah,
Heparin can be given
IV.
IV or sub-Q.
Yeah.
Okay. In the abdomen. Okay.
Mhm.
What lab values am I checking with heparin?
APTT.
Yes,
Yeah.
APTT. All right. Automatic side effects is going to be what?
Oh, let's try that. I don't
Risk
even
for
know if
bleeding.
Oh, okay.
Side effects are risk for bleeding, right? That's why we're checking the APTT. I'm checking their bleeding times because I'm preventing their body from clotting. All right. So why do patients get heparin? They've either had a heart attack in the past, they have something like AFib where their blood's not moving. Anytime your blood isn't moving, then it has the tendency of clotting. If they had like a DVT in the past, anything that puts them at risk for developing blood clots. If they're on bed rest, okay, then I'm going to be giving them heparin or low molecular weight heparin like enoxaparin or Lovenox. Okay, so we got heparin, and then we also have
Coumadin, warfarin.
warfarin, or the trade name is Coumadin.
Mhm.
Oops.
Mhm.
Okay, so this also is an anticoagulant. We're going to have those same side effects, risk of bleeding. All right, what's the route for Coumadin or warfarin though?
By mouth.
oral.
It's oral. All right, and I'm checking the PT
INR.
and INR. Okay, PT and INR. Okay. If somebody overdoses on heparin, what is the antidote?
That protamine sulfate.
Protamine sulfate.
Yep. Protamine sulfate. I might have spelled that wrong. Protamine sulfate. All right. For warfarin or Coumadin, what is the antidote?
Vitamin K.
Where can I find vitamin K?
Green leafy vegetables.
Yep, green leafy vegetables. So if somebody's taking Coumadin and they keep coming back and they're getting their labs drawn and they're taking it like they're supposed to, but it's still, the labs are still not therapeutic, what do I need to be asking the patient?
What's their diet like?
What is your diet? What have you been eating? Because they may be eating those green leafy vegetables, which is counteracting the effects of that warfarin or the Coumadin.
Mhm.
Make sense?
Mhm.
So in the
Yes.
hospital, they'll be on heparin, which is an injection, but we're going to transition them to something oral when they get home. Okay. All right. Then we have an antiplatelet, which kind of works very similarly to an anticoagulant. All right. But with an antiplatelet, it's stopping the platelets from joining together to create a plug. All right. So can y'all give me an example of an antiplatelet?
Aspirin and Plavix.
Aspirin and Plavix, correct. So it's going to prevent those platelets from joining together to create that plug. Again, same side effects though. What's my side effects?
Blood clot? No, bleeding.
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 Bleeding, yeah, bleeding.
Platelets. All right. So again, we said like aspirin and Plavix. What did I know about aspirin?
You're at
Uh,
risk for bleeding.
Yeah,
Right. Who can't have aspirin?
kids,
Children.
Children, because of
Redness
Ricin.
syndrome,
Rye syndrome. Correct. All
or
right.
Rye syndrome,
So
sorry.
some of the same indications for anticoagulants would be for antiplatelets. If they had a heart attack in the past, if they are at risk for blood clots. But with antiplatelets, we don't have to check any blood levels. Okay, so that's one of the benefits of being on an antiplatelet. We don't have to check their blood levels. But again, we still have those risk of bleeding. Okay, if somebody is allergic to NSAIDs, then they probably should not get an antiplatelet like aspirin because they work very similarly, right? If somebody has ulcers, stomach ulcers, should they get an antiplatelet or an anticoagulant?
No.
No,
Right, because what could happen?
they can bleed
Cough.
out.
They can bleed. Now, we may have some instances where we have to weigh the risk with the benefits. That means the nurse just has to have more assessment, right? But
Mhm.
yes, we worry about the bleeding of those ulcers. Okay.
Mhm.
All right. So that's antiplatelets. Now I want to talk about thrombolytics. All right.
Clot
Thrombolytics.
busters.
They're clot busters, right? So what would be their indication?
To
It's gonna
stop
break
an
up the
active
existing clot
stroke.
already.
So somebody got a
Um,
blood clot right now, which means they either having a heart attack right now, they're having a stroke, or they have a pulmonary embolism, they have a DVT, they got a blood clot right now. Okay, so this is thrombolytics. Okay, and what is the suffix for
Please.
place or ace?
Oh, okay.
Like streptokinase, alter place, right? That's the ace. If somebody's getting a thrombolytic, they have a blood
Okay.
clot right now. Okay. Same side effect though. What's the major side?
Bleeding.
Bleeding. Okay. Make sense?
Yeah.
All right. All right, then we have medications that we give for people who have conditions like hemophilia. So they bleed a whole lot, okay? And the main thing with those patients is they're missing certain factors that allow them to clot. So all we do is we give them the factors that help them to clot. But anytime we give somebody something that's going to help them clot, what are they at risk for?
A blood clot.
Right, those unwanted blood clots, okay? Let's talk about medications for cholesterol. We have HMG, CoA, reductase inhibitors. What is a suffix for these medications?
Statins.
These are our statin drugs, like lovastatin, atorvastatin. These are our statin drugs. What do I know about my statin? Where should I take it?
They're hard on the liver and the kidneys.
They're really hard on the liver and the kidneys, right? What time of day do I take it?
In the
7
morning,
o'clock.
at nighttime.
Take it at
Because
nighttime.
cholesterol is produced at night.
Because the cholesterol is produced at night, right? So it's going to decrease the production of cholesterol. Okay. Statin drugs decrease the production of cholesterol. Now we have another class of medication called bile acid sequestrants. Okay. Bile acid sequestrants. How do these medications work? Do they decrease the production?
They help the body lose cholesterol.
Correct. They help the body lose cholesterol. How does it lose cholesterol?
It eliminates it from the
stool.
bowel.
Right, through the bowel. So what do I need to make sure the patient has that works? I need to check those
Bowel.
bowel sounds. Yes, I need to check those bowel sounds. Make sure they're able to poop because that's how this medication works. So some of the side effects, they're gonna go to the bathroom more. They may have more gas because that's how this medication works. This is medication like Questran, okay? Also, what type of foods do we eat that act like bile acid sequestrants?
Oatmeal,
Oatmeal, what kind of cereal?
Cheerios.
Cheerios, yes. Again, it's going to help us eliminate cholesterol through our stool. So a lot of times when we eat oatmeal and things like that, we go to the bathroom more because we're getting rid of that excessive cholesterol. Make sense?
Mhm.
All right, tell me about niacin.
Vitamin D,
Vitamin, which vitamin? What letter are you saying?
B.
Yes. So that's our vitamin B. Niacin is also used for cholesterol. All right, this is our vitamin B. What's the side effect though?
Mhm.
It has some side effects that we can't actually fix.
Itching.
All right,
Oh, yeah,
itching,
itching and flushing.
flushing. What can we take? 30 minutes
Ibuprofen,
ibuprofen and those side effects like itching and flushing. Okay. That's the main thing about niacin that you need to know. All right. Am I missing any cardiac medication? Or any cardiac medication that you still have questions about? Questions? All right. So seems easy, yes?
it's always easy when we going over it with you.
So when I'm gonna be sitting in that, I'm gonna sit in that room with y'all. Just when you just look at me, just glance at me. Right, I will be right there with y'all. All right, let's talk about these respiratory medications though.
Mhm.
All right, we're gonna talk about the upper respiratory first. So tell me some medications for the upper respiratory system.
Robitussin DM, Mucinex,
All right, let's talk about Robitussin. What class of medication is that?
the antitussive.
So antitussives. All right. When do we give antitussives?
But like
Dry
those
cough.
dry coughs, those
Dry-
dry aggy coughs.
All right, it has to be dry cough, no productive cough. And this thing like Robitussin DM, okay? What's a narcotic that can be given to suppress cough?
Codeine.
Codeine.
Codeine, okay? Tell me another medication for the upper respiratory. You said Mucinex. What is that called? What's the class called?
Say that again. What's the one? Oh, and expectorant.
All right, expectorants. That's thing like
What?
or Mucinex, okay? How does this medication help us?
You went out. What did you say?
How does this medication help us? How does
It helps to thin the mucus so that you can get it up.
Right, so it helps us cough up that mucus. What we also tell the patient to do,
Increase their fluids.
increase fluids. That is correct. Okay. Another class of medications that we can use for upper respiratory is antihistamines. Tell me,
Mhm.
how does that help?
Well, it helps to make you drowsy, help you sleep at night.
Right, it can be used to help us sleep. What else can it be used for?
Allergies.
It blocks
Allergies.
histamine.
Okay, so it's going to dry up those secretions.
Yeah.
Runny nose, that sort of thing. So it's going to make us
Yeah.
drowsy because
Mhm.
anytime something dries up something, what kind of side effects we gonna have?
Dehydration.
Yeah.
They have dehydration, we have dry mouth, that sort of thing. Okay,
Mhm.
so that's medications like Benadryl, diphenhydramine. Okay, then we have medications like Allegra, Claritin, Zyrtec. What's the benefit of using these three medications?
They don't make you sleepy.
They don't make you sleepy. Who would benefit from that?
Children, older adults.
Are those who got to go to work, right? Who can't afford
Yeah.
to be drowsy. Okay.
Yeah.
All right. What about decongestant? Tell me about decongestants.
Can't take them longer than 5 days
Why?
unless you want to rebound congestion.
Correct. So if they're taking a nasal decongestant, it's a nasal spray, but it is a steroid. What extra things do I teach them?
Once they finish it, they can't use a nasal spray for more than 5 days.
What are we checking for if it's a steroid decongestant?
Jesus Christ.
Think about
Uh,
all steroids have the same risk. What's that risk?
I know what it is. Tachycardia. Or I don't know.
I don't know. No.
Infection.
Yes,
Oh.
it lowers your immune system.
Correct. So we're checking the nasal cavity. We're checking for ulcers. We're checking for fungal infections because it's a steroid. Anytime I talk about steroids, I don't care what condition, steroids always decrease your immune system. Always, always, always. Okay, make sense?
Okay.
So we
Yes.
have corticosteroids that can be used as a decongestant. And then we have other medications like pseudoephedrine, like Sudafed, okay, that can be used for decongestant. All right. Anytime we use nasal decongestants, like those topical ones, it's more likely to cause rebound congestion after 5 days. If you're using an oral decongestant, it's less likely to have that rebound congestion. Okay. Let's talk about the lower respiratory tract. Okay. What are some of those medications?
The bronchodilators, corticosteroids.
All right. So bronchodilators, what's going to happen?
The bronchodilators are your rescue inhalers.
What's it going to do to your airways?
It's gonna open you up.
Gonna open them up. Yep. So let's say that they're having an asthma attack right now. What do I want them to take? A corticosteroid or a bronchodilator?
Bronchodilator.
All right. Let's say they got two bronchodilators. One is a short acting, which is a SABA, short acting. We got a long acting. Which one is going to work faster?
The
The
short
SABA.
acting.
The SABA, the short acting. Okay. What's the side effects of using a bronchodilator?
Tachycardia, hyperactivity,
And older adults, how's that going to present?
as anxiety.
Anxiety or irritability.
Correct. Okay. Steroids, anytime I'm using a steroid, what are they at risk for?
Decreasing the immune system.
Right. So I'm looking for infection. They're at risk for infection. Okay. So sometimes they use a bronchodilator, and let's say as a meter dose inhaler, and they have to coordinate their breathing. Let's say they can't coordinate their breathing. What can I add to that inhaler to help them get that medication that they need?
A
A
spacer.
spacer.
A spacer, correct. What about for infants? Should
You
they
have
use
to
a
use
meter? Say it again.
Nebulizer.
sorry.
I want to use a
Nebulizer.
nebulizer. Correct, a nebulizer. Okay. Y'all, tell me about a mucolytic.
It helps with your secretions.
Okay. So for what conditions will we see mucolytic?
Emphysema,
Asthmatic.
bronchitis.
COPD.
Anytime when they got a whole
COPD.
lot of secretions in their airways. Okay. And I want them to thin those secretions so they can breathe. All right. Also, still, what do I encourage them to do?
Their rescue inhaler.
And what else? If they got a lot of secretions, what I encourage them to do?
Increase their fluid intake.
Increase their fluid intake. That is correct. Okay. Y'all, do y'all have any questions about any of this content?
No.
No questions?
No,
Then of course I'm gonna put those labels on there, so that'll be on there as well. Okay, but again, so I have recorded this. I am going to stop